Dr. Hunt just showed you some of the new studies that have been published and some of the new evidence that we've been considering. Now it's the time to see how you can apply this to your patient in your office. So we're going to be talking about persistent dyspnea and how we might manage that now in 2025. To illustrate this, I'm going to start off with a hypothetical patient. This is Sheila. She's 68 years old. She's a female, and her chief complaint in your office is that she has ongoing daily dyspnea, which limits her activity. Very familiar situation for most pulmonologists. So I'll take you through some of the key historical points here. So her history, to elaborate a little bit further, she presented with progressive dyspnea over the last week, so it's important to get that timeline. She notes the extent to her symptoms include being very notably short of breath with very little exertion, things like walking short distances or carrying groceries. She does note that she has had an increase in her productive cough, and the sputum has been yellow in color. She does have a history of moderate COPD, which is fortunate to know. Some patients don't come in with that diagnosis, but in this case, we have a history that she was hospitalized 6 months ago for a prior exacerbation. Her comorbid conditions include hypertension and osteoarthritis, and she really hasn't been adherent to her daily maintenance inhaler. She's been allergic to sulfa drugs, and the last time she saw a pulmonologist was over a year ago, and she comes to your office today. So currently, she says that in terms of medication, she's been on a LABA-LAMA combination, and this was given to her 10 months ago. This has been documented in the chart that she really has had suboptimal symptom control, even when she does use her medication. She had been switched from a monotherapy, which is tiotropium for her, because she was still short of breath. And she's been using her albuterol about 2 to 3 times a week. She has been a non-adherent with some other modalities that have been prescribed to her in the past, including pulmonary rehab, and also didn't really come to some follow-up appointments. She has no history of ICS use. In terms of her social history, she lives alone in a rural area. She uses a wood-burning stove for heat, and she does admit to a 40-pack year smoking history, but fortunately quit 5 years ago. Her family history is significant for a father who died of an MI at 72, a mother with obstructive lung disease and diabetes, and a sister with an autoimmune condition. She has a prior surgical history, which is really non-contributory here. So I mentioned earlier in this session that, we really have not changed our baseline definition of frank COPD, which is really based on physiology. And so here on the left, I'm showing you a tracing of a normal spirometry tracing. You can see here volume versus time, where the patient is exhaling, and you can see with increasing time of exhalation, the patient achieves pretty a significant and sufficient amount of air that they're able to generate. On the right is what defines airflow obstruction, and you can see the same graph, but the patient does not achieve a high enough volume over time, despite extending it out to 6 seconds. And in fact, the amount that they're able to breathe out is much more diminished. So this basically is the tried and true way of measuring airflow obstruction. It's still in 2025. However, our classification gets a little bit more granular here. And so according to GOLD criteria, in terms of GOLD 1 through 4, you can see we've classified disease in terms of mild, moderate, severe, and very severe. And this does take into consideration thresholds in FEV1 as well as categories. What's a little bit more of an advancement over the last several years has been the incorporation of symptom data, which I mentioned earlier is usually obtained through questionnaires the patient fills out in the office. Here I'm showing you the modified MRC dyspnea scale, or the MMRC, which basically gives you a grade of 0 to 4, depending on how morbid that patient's dyspnea is. And the patient is only supposed to tick off one box here, which best describes them in terms of the degree of shortness of breath that they have with various activities. And this is very helpful to follow as well from visit to visit. Similarly, here I'm showing you the CAT assessment, or the CAT assessment, in which various domains of their COPD or morbidity are assessed. This includes things like cough, chest tightness, dyspnea with exertion, and other aspects of their disease. And so incorporating both the lung function data as well as these symptoms arrives at this particular assessment tool where you can see that both are integrated into determining what type of COPD or what box they fit in. And this we went over just previously, so I won't dwell on this, but you can see that this is a very helpful algorithm to define the patient that you're seeing in real time. So back to Sheila. So on exam, her physical exam is significant for being mildly tachypnic. She was using accessory muscles during breathing. She definitely started to pause occasionally to catch her breath while she's talking to you. Her vitals are pretty much normal, other than the fact that she's 92% on room air. And was a little bit tachypnic. Her extremity exam was pretty much unremarkable. Her lung exam was significant for decreased breath sounds with some scattered wheezes and certainly hyperresonance on percussion. She did have a prolonged expiratory phase, which is to be expected after seeing her spirometry, and her cardiac exam was unremarkable. So here I'm showing you an ABG in this hypothetical patient. Very unusual that you would have an ABG in real time in an office setting, but it does happen. And certainly if the patient was recently hospitalized, you might have this data in front of you to incorporate. We see here that the most notable finding here is that the patient is mildly hypercarbic with a PaCO2 of 52. Actually, I also want to point out that her pH is fairly normal at 7.38. Furthermore, you have some lab data here, which you can see that a CRP, which is a measure of nonspecific inflammation, is mildly elevated. Notably, her BNP is normal at this point, and her hemoglobin is also within range, if not a little bit more elevated. So you can see here that her spirometry is consistent with a moderate airflow limitation. Her FEV1 percentage was 48. It's not shown here with raw data, but there was no significant bronchodilator reversibility, which strengthens your idea that this patient in front of you has a diagnosis of COPD that is true. And here's some additional imaging, also not usually available in real time in a visit, but also sometimes available from other visits. You can see here that the chest x-ray is fairly unremarkable with regards to having an infiltrate or other intraparenchymal process, but does show some hyperinflation. You can see from the flattened diaphragms that there's an increased diameter consistent with COPD. So how do we treat this patient? So we've established that this patient has dyspnea. They were initially on a Spiriva, and was then stepped up to a LABA-LAMA combination. And so we're really here kind of already at the level that we would normally prescribe for dyspnea. And where we've been stuck for several years, where we didn't really know what else to do for our patients who continue to have symptoms, even despite being on maximal therapy. And so in 2025, it's really promising to see that a new drug has been added to this algorithm, ensifentrine, which Dr. Hahn highlighted some of the evidence surrounding, which basically is a nebulized formulation, which can be considered as an add-on therapy to patients like Sheila who've already been on a LABA-LAMA combination. And so this is an example of switching or adding on a different type of molecule to the existing treatment in order to have a better control of the patient's morbid symptoms. So finally, in terms of this patient's treatment already, you can see that we've already optimized her inhaler device. We tried to do some inhaler technique. Those were all fine. She was already sent to pulmonary rehab, so that's in place, although she didn't quite take the full advantage of that. Other causes of dyspnea were preliminarily ruled out. These include anemia, cardiac etiologies. Can be very difficult to tease apart some of these comorbid conditions, especially psychosocial presentations of dyspnea. But we've so far tried to address each of these. But she's still having persistent dyspnea. And so ensifentrine was added because it was a dual bronchodilator and because it has anti-inflammatory effects on top of her existing regimen. So I know that Dr. Hahn went over some of this, but I just want to reiterate what we know currently about ensifentrine. There have been several studies since its arrival, and more recently, a few meta-analyses. This is data from one meta-analysis, which included 5 randomized controlled trials. This included over 3,000 patients, where they found that at addition of ensifentrine significantly improved lung function, dyspnea scores, quality of life outcomes, as well as an exacerbation rate, particularly in patients patients with frequent exacerbations. It was very well tolerated in comparison to placebo arms. And so what this really means for our patients is really revolutionary for those of us who have seen time and time again that our patients just continue to have dyspnea. You've ruled out everything else. They're taking their LAMA LAMA, they're taking it correctly, and they still can't do what they want to do. And so this evidence really supports the add-on use for ensifentrine for people who are symptomatic. These are forest plots on the right, which show each of the domains that I mentioned, and you can see that there's significant difference for each of them with the addition of the drug. A little word about triple therapy, and trifunctional agents. So currently we are used to multimodal medications or cocktails, if you will, that include multiple drugs. We've really advanced our understanding that these cocktails are not just multiple agents just stuck in one bottle, but they might have synergistic um, uh, activity with the other ingredients in those inhalers. And this is potentially true for ensifentrine um, and the LAMA component of their medication. And certainly not just is there a synergistic effect, but it also allows patients to have some streamlined alternatives, right? Not to have so many different agents, but really to be able to use their drugs effectively without the burden of having to take so many drugs as well. So definitely having a trifunctional agent makes it easier. And so since ensifentrine is inhaled, thoughts are about maybe kind of combining all of that so the patient can have really nice delivery through a single agent. There's a lot of work to be done further in this area. I just want to touch upon it a little bit because these are the things that are coming down the pipeline. And really, trifunctional inhaled agents are something to look out for, and they may represent the next advancement in simplifying and optimizing our management. So in summary from this case, we notice that dyspnea, despite dual bronchodilation, really requires a real reassessment of all the different components. How are they using their device? Are they using it correctly and frequently the way they should? Do they have other comorbid conditions which are confounding their source of dyspnea? And what other non-pharmacologic strategies have we tried in this patient? Beyond that, we have new medication in the form of nebulized ensifentrine, which allows for the bronchodilation and anti-inflammation that might help patients like Sheila, who currently are not getting that optimized in their current regimen. We've done all those things in this hypothetical patient, but I also want to urge you that although many of the elements that Sheila manifested are things that we see on a regular basis, it's really that Goal 2025 has really emphasized a personalized approach. So not just taking the algorithms that I've shown you, but really incorporating patient level data, trying to understand what's going to work for them and how to escalate their care. So with that, I'm going to pass it back to Dr. Hahn, who's going to be talking about exacerbations in a different case.